All right, so our first topic is among individuals at average risk for colorectal cancer, should screening be initiated at age 45 instead of 50? And Dr. Ladabaum will take the yes on this topic.
So the answer is yes, and I'll try to convince you why that's the case. This is a very famous paper by Becky Siegel and colleagues that looked at what has been happening over time in terms of the risk of colon cancer on the left and rectal cancer on the right. It's a little dense, so let me walk you through it. You'll see that at the bottom, we have birth cohorts. So these are the years that different groups of people were born. And the question is, what happens to the age-specific incidence of colon cancer here on the left side or rectal cancer as we move through time? Let's look, for example, here at the 70 to 74-year-old age range. As we look at people who've been born later and later in time, in calendar time, the risk of getting colon cancer at those ages has dropped. You've seen this in different forms, but this graph puts it all together. And what's very striking is that for older people, the age-specific risks are going down, starting in the late 50s for colon cancer here, rectal cancer on the right here. Why is this? Well, there's no way to prove it from these figures, but most people think that screening must have had some impact. Even if we don't take all the credit for this diminution, there is a belief that much of this is screening. It's unlikely to be just environmental things. And part of the reason that the argument, I think, is strong is that if you look at what's happening at the rates in younger people, they're increasing. So you would have to argue that whatever's in the environment is making things worse for younger people and better for older people if you don't think that screening is making a difference. Now, let's look at the main age ranges here that are under contention here. 50 to 54-year-old, onset of colon cancer, or 45 to 49, and you see the numbers here. Patterns the same. In recent time periods, the numbers have been going up. They've been going up. And if you see what's happening in 45 to 49-year-olds here in the pink, it is really starting to look like what the 50 to 54-year-olds used to look like before. So remember this orange and pink for these two age ranges. Some of you may remember this show, Orange is the New Black. So the argument here is that pink is becoming the new orange, and that's really important. That's why what used to be 50 is now 45. Let's move down what we did at 50 to 45. Here's another way to look at it. These are 50-year-olds in the year 2000, when many of us were already doing colonoscopies on these people. And what's happening to the estimate of their lifetime risk of a cohort's lifetime risk of rectal cancer and colon cancer, these are today's 45 and 49-year-olds right here. They have an incidence rate ratio estimate of about 4-fold for rectal cancer and over 2-fold for colon cancer. Very strong argument that we should start doing something early. We recently tried to model this out. The question is, what would be the impact of actually implementing this in the population, and is it acceptable for society? So what we illustrate here is that if you were to start a colonoscopy program at 45 instead of age 50, and you did that for 1,000 people, over the lifetime of the cohort, you could avert 4 cancers, you could avert 2 colorectal cancer deaths, you would gain a certain number of quality adjusted life years in this cohort. Yes, it does cost you more, and you do have to do more colonoscopies here, about 760, but this is highly cost effective at $34,000 per quality adjusted life year gained. And if you're a fan of FIT and you start FIT at 45 instead of 50, the effectiveness numbers look about the same. You avert about 4 cancers, you avert 1 cancer death, similar number of qualities gained, and this is much more cost effective. What I'm not showing you in this slide is that one of the co-authors of this paper was a certain Samir Gupta. So I want to see what my worthy opponent says about this. If we continue on, what do people do? What's the behavior? Because we know that the ultimate impact in the population is whether people get screened or not. And you all know that we've been disappointed that we haven't reached the 80% goal nationally that we have wanted to see. We plateau in the upper age groups in the US in the low 60s, with most people doing colonoscopy, some people doing FIT. And despite the messages to start getting screened at 50 that we've had until now, less than half of the population gets screened in the early 50s. This is a missed opportunity. I would argue that if we get the message out there to start screening in the 40s at 45, some may do that, some may delay, but we would still gain in terms of participation overall by attempting to shift this to the left a little bit and have more people actually come in when they should. So why start screening at 45? Very simply, today's 45-year-olds are like yesterday's 50-year-olds. You may hear from Samir that we don't have evidence that this works in 45 to 49-year-olds, but I think there's no reason to believe that screening won't work at that age range. It's not like it's a fundamentally different disease in the late 40s versus the early 50s. And there's some emerging data of the yield of looking for lesions at those ages. It is estimated that if we do this, it'll be cost effective. And most importantly, in the US, I think we can do it. We have the resources to do it. And if you're worried about colonoscopy supply, it can be done with FIT. And finally, if we start the message early, that'll make a difference because people act late. I'll stop sharing. Samir, it goes to you.
Well, good morning, everyone. Got a formidable opponent here, and it's really my pleasure to have a chance to debate Uri about this. I'm going to say no. The incidence is rising, but the absolute risk is low. Uri showed you some impressive data, but conveniently neglected to point out that his y-axis was on a log scale. And to put a point on this, the current incidence among 0 to 49-year-olds ranges from about 6 to 7 per 100,000, compared to between 70 and 90 per 100,000 among 50 to 64-year-olds, and 150 to 225 per 100,000 among those older than 65. These people have much, much higher risk than people under 50. And to me, this emphasizes the importance of getting more people over 50 screened than screening those under 50. The second point I'd make is the projected benefit of starting earlier is small. For every 1,000 persons screened starting at age 45 instead of 50, there will only be 3 fewer colon cancer cases and 1 less death. And we would be asking 22 million people between the ages of 45 and 50 to start screening earlier. It's also important to note that models have used many assumptions, including about uptake and the effectiveness of the screening tests under age 50. And I don't worry so much about the effectiveness in terms of sensitivity and specificity, but how the timing of when you do these tests might throw things off. What does it mean to have a colonoscopy at 45 and not do it again until 55 instead of doing it at 50 and then repeating it at 60? I think it's also true that investing in increasing screening over age 50 is cheaper and more effective than starting screening at age 45. For example, this abstract shows that given a fixed amount of money that's available to improve colon cancer screening, investing in increasing screening rates among those over 50 compared to starting screening at age 45 will result in many more cancers prevented and many fewer colorectal cancer deaths. And said another way from this study, a luminary professor once said, given the choice over how to deploy a fixed number of colonoscopies, the clinical benefits would be far greater if screening were performed among the 44% of 55-year-olds and 37% of 65-year-olds who remain unscreened, or if colonoscopies were allocated to improve colonoscopy completion after abnormal FIT, than if average risk screening were initiated at age 45. I also worry about unintended consequences. And the one that I worry about the most is with regard to healthcare disparities. We know that racial ethnic minorities, those who are foreign born, and those with lower socioeconomic position are less likely to be screened. I really think we need to focus new investments on screening for increasing screening among these groups rather than starting at age 45. So for example, this graph shows colon cancer screening rates before and after implementation of the Affordable Care Act, stratified by racial and ethnic groups. And what you can see here is that despite expansion of healthcare coverage, which we thought would address healthcare disparities, the screening rates among racial ethnic minorities are much lower than among non-Hispanic whites. So non-Hispanic whites being at about 70%. The cream color bars show that in order to get to a goal of 80% screening in every community, really big absolute changes in screening participation are needed, which will take really big investments. And if we go with screening at age 45, I worry we take our eye off the ball of addressing these disparities and really are not investing money in the right place. So to close, incidence is rising, but the absolute risk is low. I think the projected benefit of starting earlier is small. Optimizing screening above age 50 would be way cheaper and more effective than starting at 45. And I do worry a lot about the unintended consequence of increasing cancer disparities because we're not focusing on the highest need, highest risk populations by investing new resources in getting those who are unscreened above 50 screened.
Well, thank you both. I think we can conclude that one of the downsides to being so well published is that your words can clearly be used against you in the debate. But for the big reveal, Dr. Gupta, Dr. Ladabaum, what are your thoughts about screening at 45 versus 50?
Who's first?
You,
Go ahead.
All right, my big reveal. So I think Samir's points about the potential trade-offs are absolutely right. I do think that if we have a choice, there are higher yield interventions. Older people, and in terms of just social fairness, we need to look at equity. So I would say if we can do that and also lower the screening age, I would lower the screening age. I do think the epidemiology is such that even though the incremental gain appears small, it's important, it's worth doing. Those are cancers that happen at crucial times in people's lives. So I would lower the screening age, but we have to take care of the other things. And while it's relatively easy to talk about these potential trade-offs, the reality is that it's not that easy to achieve higher uptake in the 50, 60-year-olds who are refractory, and sadly to reach some of the underserved populations. So although it's easy to say, let's do that instead of lowering the screening age, I worry that it's a lot harder to actually achieve that. So if we get the package, I would do the whole thing.
Yeah, I think we're very close on this, Uri. You know, from an epidemiologic standpoint and on an individual level, if I were talking to a patient in front of me, I think it makes sense to lower the screening age. I think the epidemiology is pointing in that direction. It's only getting worse. The real challenge here is, you know, we do have limited resources, and the question is, you know, who's paying? And it's so much easier for us to reduce the screening age and get insurance coverage for that than to do the hard work of making companies pay for things like mailed outreach programs. And I would say, I'd emphasize, I know there are a lot of people from KAISER Northern California on this. I mean, we have the model for how to do it. I mean, they achieved 80%. They were aggressive. They took a population standpoint. They showed they were able to reach their Medicaid population. So I think the really hard part and what I think is going to happen is the screening age will be lowered, and we'll continue to try and fight for more resources to get the higher risk people done. And I just don't see that as a win. And we'll just see how it rolls out.
very good. So I think recruitment is one issue, but if a 47-year-old came to you asking for a screening colonoscopy, you guys would say?
Yeah, I'd probably say yes. I mean, I want to explore a little bit more why they want it, but no.
All right. So thank you guys. Should we move on to the next topic? All right, so question number 2. Among individuals with a low-risk adenoma, which are 1 to 2 adenomas less than 10 millimeters in size, should a shorter, i.e. a 5-year interval versus a longer 10-year interval be recommended? And we'll have Dr. Ladabaum start with yes, the emphatic yes.
So the answer is yes. Why is that? I suspect Samir will show you some curves that look like this. There are various studies that are accumulating now. What does this show? This shows the cumulative colorectal cancer incidence over time as a function of what group people were in when they entered the particular observational study. And this comes from the PLCO study, which was a sigmoidoscopy study. And the design was that if you found polyps, you went on to colonoscopy. So it's not a screening colonoscopy study, but be that as it may, these are people who ultimately, after their entire evaluation, either had no adenoma down in the orange, or they had non-advanced adenomas in the light blue, or advanced adenomas in the darker at the top. And you see that over time, the people who had advanced adenomas at baseline have the highest cumulative colorectal cancer incidence. And the question is, are the two curves at the bottom the same? Are they not? Are they different enough that we should do something different for the non-advanced adenoma group versus the no adenoma group? And as you know, the no adenoma group, if they're in a colonoscopy surveillance or screening program, they come back at 10 years. So the question is, do we tell the non-advanced adenoma people come back a little earlier than that? Now, the confidence intervals overlap here, but let's review exactly what that means. The estimate here for the relative risk for the non-advanced adenoma group versus the no polyp group, the point estimate is 1.2. The confidence interval does cover 1. It goes down to 0.8, but the upper bound is as high as 1.7. So the question is, how do you interpret the statistics? Is this absolute proof that the non-advanced adenoma group is the same as the no adenoma group? Or do you say, there is a substantial probability here that the risk for the non-advanced adenoma group is higher? And I would argue that we have to still think about the latter and say, those groups look a little different to me. Let's look at some data from KAISER, where there's a very similar graph, but there are also these graphs in the paper. The top figure is when the cancers happen in the no adenoma group over time. And you can see that for the first 7-8 years, there's not much. Then they happen a little later in time. This is different in the low risk adenoma group, where the cancers happen early. And this gets complicated, and I'll make the point why in a second. But if you look at this visually, it does kind of tell you, well, maybe I should be looking in these people a little earlier. If we look in the right here, we have a similar thing as we saw in the previous graph. The high risk adenoma group is definitely higher, and here are the confidence intervals, clearly different from the no adenoma group. The low risk adenoma group visually looks higher. Confidence intervals don't quite make it, but let's be honest. If you step back, would you say, there seems to be an acceleration here? Or are you just going to say, slam dunk, low risk adenoma group's the same as the no adenoma group? And I'd say, no. And if you just think biologically, totally normal colon versus a few adenomas, knowing that we miss things, are these people at somewhat higher risk? And I would argue they probably are. Now, let's dig into this a little bit more, because this is not an uncontaminated observation. What happens to these people over time? Well, you're all practicing out there. How are you managing these people now? The no adenoma group, most of the time you're telling them, see you in 10 years. So by year 6, how many of these people have had another colonoscopy? It's only 9%. And what have you found? Well, they usually don't have advanced neoplasia. 1.7% of them have had an advanced adenoma. But what about the low-risk adenoma group? Well, the guidelines have changed only recently. Samir's one of the co-authors. He pushed for 7 to 10 years. But were we practicing that way before? Absolutely not. So what happens by year 6? The data that Jeff Lee and others published is affected by this. What we have is that 40% of these people in the low-risk adenoma group had a colonoscopy. There was a 4% find rate for advanced adenoma. So the numbers that we're seeing for cancer down the road are affected by this. And you'd have to ask yourself, do I believe that in my colonoscopies where I'm finding advanced adenomas, I'm helping these people? I'm decreasing their cancer risk. And if the answer is yes, then you'd have to say, look at this. The risk for the low-risk adenoma group of cancer over time is looking a little higher than for the for the no adenoma group already. And on top of that, I've affected that natural history downward by doing colonoscopies and removing some adenomas. So be careful when you look at the graphs that Samir's going to show you, because they're affected by this. How have people actually been managed? Now, we tried to model this out. This is using the MISCAN model kept at Erasmus. The lead author here was Rainier Mister. And what I'm showing you here is what happens to a group of people who have low-risk adenomas detected at baseline by colonoscopy. And if you do no further screening or surveillance in those people, this is what happens to their cancer risk over time, all the way through into older ages, the 80s and the 90s. If you return them to routine screening, which is essentially saying come back in 10 years, we have this dotted line here. If you go for what we called low intensity surveillance, which is surveillance in 10 years, those look essentially the same as they should. High intensity surveillance here was coming back at 5 years. And these curves do diverge. Remember, we're starting at age 50, but by age 70, they're starting to look a little different. And into the 70s, 80s, 90s, there is a little difference here in the cumulative cancer rate. It's not enormous, but it's there. And the question is it worth paying for this? Our estimate was yes. Doing this at 5 years versus 10 years, that little small increment was very highly cost effective, $18,400. Very similar curves here. If the low risk adenoma is detected by FIT, you see the difference here is a little bit more accentuated and highly cost effective. So why do low risk adenoma surveillance at 5 years? Well, even with the interval surveillance that you can say is affecting the results in the low risk adenoma groups, the upper bound confidence intervals for the difference versus no adenoma has some meaningfully increased risk. And if you think biologically, I think you probably say, no, the two groups are not identical. The low risk adenoma group is a little higher than the no adenoma group. Without interval surveillance that happens in the interval at less than 10 years, I think the colon cancer risk would look even worse in the low risk adenoma group versus the no adenoma group. It can take a long time, greater than 15 years to see the effect. This has not been studied yet. We tried to model this out. And finally, it's estimated to be cost effective, and we can do it. So for this particular question, yes, the juice is worth the squeeze. Samir, to you.
Thanks, Uri. Obviously, I'm going to argue that it should be longer. The first point I'd make is that these patients are at very low risk for metachronous advanced neoplasia. This is a meta-analysis that included 8 studies, 10,000 patients, and among people who had no adenoma at baseline, 3.3% had advanced neoplasia on follow-up, and among those who had low-risk adenoma, it was 4.9%, and this was not significantly different. This is very different than what we see in the group who had advanced adenoma at baseline, which was 17%. These patients have low risk for incident and fatal colon cancer compared to the general population. This study by Cotet showed that colon cancer incidence is reduced among low-risk adenoma patients with a standardized incidence ratio of 0.68. And this study by Loberg, which was in the New England Journal of Medicine, showed that the standardized mortality ratio for people who had low-risk adenoma compared to the general population was 0.75. And I think most compellingly, we have lots of data now that shows that people with low-risk adenoma are at low risk for incident and fatal cancer compared to those with normal colonoscopy. You've got the CLIC and SHOWN study that Uri just showed you. There are these 3 very large longitudinal cohort studies, and there's one more by David Lieberman from the VA. And let's walk through some of these data. These data show the cumulative incidence for colorectal cancer. And here are the data from normal, which range from 0.24 to 0.4% versus in the low-risk adenoma group where they range from 0.3 to 0.44%. For mortality,